Welcome to Behind the Genes.
The first difference is that the model we've traditionally had around clinical ethics, which sort of assumes it all focuses around the patient individually, is not enough to deal with the challenges that we have, because we also have to understand how we support families to take decisions, and families differ enormously. Some families are united, some families have very different needs amongst them, and we have to recognize that our ethical approaches to genomic issues must respect everybody in that.
My name is Natalie Banner, and I'm the Director of Ethics here at Genomics England. On today's episode, I'm joined by Chair of our Ethics Advisory Committee, Professor Sir Jonathan Montgomery, and Dr. Latha Chandramouli, member of the Ethics Advisory Committee and the participant panel, who's also a community paediatrician working with children with complex needs. Today, we'll be discussing why ethical considerations are crucial in genomics research and clinical practice, and what consent means in the context of genomics. If you enjoy today's episode, we'd love your support. Please like, share, and rate us wherever you listen to your podcasts. At Genomics England, we have an Ethics Advisory Committee, which exists to promote a strong ethical foundation for all of our programs, our processes, and our partnerships. So this can mean things like acting as a critical friend, an external group of experts to consult. It can mean ensuring Genomics England is being reflective and responsive to emerging ethical questions, especially those that arise as we work with this really complex technology of genomics that sits right at the intersection of clinical care and advancing research. And it can also ensure that we are bringing participant voices to the fore in all of the work that we're doing. I'm really delighted today to welcome two of our esteemed members of the Ethics Advisory Committee to the podcast, Professor Sir Jonathan Montgomery, our chair, and Dr. Latha Chandramouli, member of our participant panel. So, Jonathan, if I could start with you, could you tell us a little bit about your background and what you see as the role of the Ethics Advisory Committee for us at Genomics England?
Thanks very much, Natalie. So my background professionally is I'm an academic. I'm a professor at University College London, and I profess healthcare law, the subject that I've sort of had technical skills in. But I've also spent many years involved in the governance of the National Health Service. So I currently chair the board of the Oxford University Hospitals NHS Foundation Trust. And I've spent quite a lot of time on bodies trying to take sensible decisions on behalf of the public around difficult ethical issues. The most relevant one to Genomics England is I chaired the Human Genetics Commission for 3 years, which was a really interesting group of people from many backgrounds. The commission itself was primarily combined academics in ethics, law, and in clinical areas. And there was a separate panel of citizens grappling with things that are really important. Genomics England has a bit of that pattern, but it's really important that the Ethics Advisory Committee brings people together to do that. And you asked why ethics is important and how it operates. I suppose the main thing for me is that these are tricky questions, and you need all the voices, all the perspectives, all the experience in the room working through at the same time. You don't want to have separate discussions of things. So my aim as chair of the advisory committee is essentially try and reassure myself that we've heard all the things that we need to hear, and we've had a chance to discuss with each other as equals what it is that leads us to think, and then to think about how to advise within Genomics England or other people on what we've learned from those processes.
Fantastic. Thank you, Jonathan. And as you mentioned, the necessity of multiple different perspectives, this brings me to Latha. You have lots of different hats that you bring to the Ethics Advisory Committee. Could you tell us a little bit about those?
Thank you, Natalie, for that introduction. I'm Latha Chandra. I'm a Consultant Community Paediatrician, and I'm based in Bristol, employed by Sirona Care and Health. And I'm a parent of twins. And from my personal journey, which is how I got involved, my twins are now 21, so doing all right. But we had a very, very stormy, difficult time when they were growing up with our daughter having epilepsy, which just seemed to happen quite out of the blue sometimes, started to increase in frequency the year of GCSE, to the point that she would just fall anywhere with no warnings and hurt herself. This was difficult for me because as a clinician, I was also treating patients with epilepsy. I also was looking at the journeys of other people and was able to resonate with the anxiety as a parent when I worry about sudden death in epilepsy, for example, at night. These were the kind of difficult conversations I was having with parents, and I was now on the other side of the consultation table. I was also doing neurology in those jobs and in a unit where there was epilepsy surgery happening. So it was, in very simple terms, very close to home. And it was quite hard to process, but equally, my job, I felt, was I should not separate myself from as a parent, but also as a clinician, because I had information, I had knowledge. And we had conversations with my daughter's clinician, and we were then recruited into the 100,000 Genome Project, which had just started. So we were just the year after it got started. And that was an interesting experience. We were in a tertiary center with a lovely clinical geneticist team. We had the metabolic team. We had loads of teams involved in our daughter's care. So we could understand as a clinician, but there was also my husband, although as a clinician, was not into pediatrics and was in a different field. So it was important that it was a whole family getting recruited into the journey. And also my daughter also was quite young. So obviously we have parenting responsibility, but we were very keen to make sure they knew exactly what they were getting into in terms of the long-term issues. And despite being informed, at times there were things that we went in with without understanding the full implications, because life happens in that odyssey. And I think that's what was my biggest learning from those exercises when I began to question certain other things, because I then had a breast cancer journey, but obviously I was not recruited as part of that process for the 100K. And those were kind of some of the questions coming in my head. How does that dynamic information sharing happen? And that's how I got involved, found out a bit more about the participant panel. And that's how I got involved from 2018, which has been an interesting experience because, firstly, I think with the Genomics England, they are probably one of the groups of organizations having a big panel of people genuinely interested in wanting to make a difference and represent thousands of participants who have got their data saved in the research library, and recruited under the two broad arms of cancer and rare disease. So we were under the rare disease arm, although I could resonate with the cancer arm because of my own experience. And at various times, there were lots of opportunities to think about, how is data accessed? Are we getting more diverse access to data? All those different issues. At various points, we have been involved in asking those questions. And at those points, I also we all have different skill sets, you see, in our group. Some have got information governance hats, some have got data hats and PR hats. I've got a clinical hat and a clinical educator hat. I'm a pediatrician, so I have recruited people for the DDD, for CGH, etc. So I've always gone through the principles of consenting, confidentiality, the ethics. I also work in a field, Natalie, where there is a huge, as you're aware, with the NHS resource issues, there's huge gaps and waiting lists. So it's trying to make sense at what is the best thing to do for that patient or that family at that point in life. And how are we obsessed by a diagnostic label? Are we going down a needs-based approach? So it's having always those pragmatic decisions to be made. So that's one of my clinical hats. I also am an educator. So I'm very keen that young medical students, be it nursing students, everybody understands genomics and they're signing up to it so that you can mainstream genomics.
Fantastic. Thank you, Latha. There are so many different perspectives there. You talk about kind of the role of the whole family as part of the journey. You talked about sort of consent, confidentiality, data access issues, lots of questions of uncertainty. And I wondered if you might, and perhaps Jonathan, I can come to you first, talk a little bit about what is it about the ethical issues in genomics that may feel a little different? Are they unique, or are they the same sorts of ethical issues that come across in other areas of clinical practice and research? Is there something particularly challenging in the area of genomics from an ethical perspective?
Thanks, Natalie. Well, I think all interesting ethical issues are challenging, but they're challenging in different ways. I'm always nervous about saying that it's unique to genomics because there are overlaps with other areas. But I do think there are some distinctive features about the challenges in genomics. And I suppose I would say they probably fall in three sort of groups of things that we should think about. The first you've touched on, which is that information about our genomics is important not just for the individual person where you generate that data, but it's important for their families as well. So I think the first difference is that the model we've traditionally had around clinical ethics, which sort of assumes it all focuses around the patient individually, is not enough to deal with the challenges that we have, because we also have to understand how we support families to take decisions, and families differ enormously. Some families are united, some families have very different needs amongst them, and we have to recognize that our ethical approaches to genomic issues must respect everybody in that. So I think that's the first difference. I think the second difference is that the type of uncertainty involved in genomics extends much further than in many other areas. So we're talking about the impact on people's whole lives, and it's not like a decision about a particular medication for a problem we have now or an operation. We're having to help people think about the impact it has on their sense of identity, on things that are going to happen sometime in the future. And then thirdly, I think the level of uncertainty is different in genomics from other areas of medicine. And the particular thing I think is different that we have to work out how to address is that we can't really explain now all the things that are going to happen in the future because we don't know. But we do know that as we research the area, we're going to find out more. So what are our obligations to go back to people and say, we worked with you before and you helped us out giving data into the studies. We couldn't tell you anything then that would be useful to you, but actually we can now. Now that's different. That continuity sometimes talked about what are our obligations to recontact people after a study. You don't usually have those in the ethical areas we're familiar with. You're usually able to deal with things in a much more focused way. So I think those differences, that it's not just the individual, it's the family, that it's not just about a specific intervention, but it's about an impact on people's lives, and that we'll need to think about what we have to do in the future as well as what we do immediately. They make it different in genomics. Some areas of healthcare have those as well, but I'm not aware of anywhere that has all of that in the same position.
Latha, I'm wondering if that kind of resonates with your experience, particularly the navigating of uncertainty over time.
Yes, I would say that's exactly what you've said, Jonathan. I think it's the whole process of consenting with the view that you do not know much more beyond what you know about the situation here and now. And part of that is like any other situation that you that's why we have evolved from, I would say, penicillin to the SMA gene therapy. So that's, that if we did not do this, we wouldn't reach frontiers of medicine. And kind of that's how I explain to families when I'm recruiting. And I'm also very clear that it's not all about research, but it's a combination of the two. I'm focusing on you, but it's also helpful for research. So even if you do not get answers. And I think it's very important at that stage, Natalie, that we have to be clear. We may not get many answers at the very outset. And also, when do we look at data? Do we have that kind of realistic, pragmatic resources to be able to relook every time? Is there a method of dynamically having that information from our NHS spine? If somebody of the trio has contracted a condition, would that be fed in? Those are the kind of questions parents and families ask. I cannot honestly answer that. And I often say that is optimal plan. If things go to plan, that will be the area we'd be heading towards. But currently, I can't give you timelines. And I think it's important we are honest at the outset and manage expectations. And that's how you engage families. And in my case, it's more these children and families. So engaging is crucial. And as you mentioned, is also the question that gets asked is very simply in my mind, sometimes there's that conflict because of my own personal recruitment to the 100K project. I have an interest in genomics, and therefore I would be very keen to embark on that journey. And I feel that is the way forward. But I also understand, as a member of my clinical team, for example, where I know there's a huge waiting list, how am I best using the taxpayers' money that's been entrusted to us? If I think the waiting list is so high, can I see 2 further patients in that time that I'm using to consent, which is not going to add much more to that child's journey, for example, with autism or ADHD. So it's trying to be careful. Where is the ethics in doing an investigation? And that's like in any situation as a clinician. So I think that's not much different, but it is kind of similar, but it opens up a huge area of uncertainty. As you would with any investigations. If you just went and did scans on everybody, you might pick things up which you don't need to do anything about. So it's being sensible and being honest.
And for me, Latha, that raises 2 areas which I think are really interesting about genomics. The first of those is the language we've tended to use about consent, I don't think captures all the ethical issues that we raise, because we've tended to think about consent of something that happens once and then gives people permission to do things. Whereas what you've described and what we find ourselves often thinking about is that we have to get a respectful relationship with people. So the consent is not to doing certain things, it's to agree to be part of what I think about as a common enterprise. So patients and families are partners with the clinicians and the researchers, and it's not that they sign a form and then the consent issue goes away, which is how lawyers tend to think about it. It's that we're starting something together, and then we need to think about how do we keep the conversation going with mutual respect to make sure that everybody's values are there. And I think the second thing you picked up is a sense of the need for a better explanation of how research and care interact with each other, because the care we get now is built on the evidence that people have contributed to in the past. So we're benefiting from our predecessors, and we want to contribute to our successors and our family getting better care in the future. And I think one of the things about genomics is that the gap between those two things is really non-existent in genomics. Whereas if you take a medicine, the research that's been done to make sure that medicine is safe and effective will have been done on a group of people sometime in the past that I'll never meet. Whereas in genomics, I'm part of the production of that. I may get some benefit now. My friends or family may get some benefit, but there isn't this sort of separation between the care and the research bit that we're used to being able to think about. So this is a much more mutual exercise, and the stakes that we all have in it are therefore intertwined much more closely than they are in some areas of medicine.
I agree totally. In our case, for example, I went in thinking, oh, we might get a targeted medication. And I know there are certain levels of epilepsy medications anyway. So, in principle, it wouldn't have mattered a lot. However, it was important to know what the outcome was going to be because we had various labels put: potential mitochondrial disease, potentially some susceptibility disorder. So we were on a spectrum from something very minimal to the other end of neurodegenerative situation. So we were left dangling, and we thought it'd be good to embark on this journey. At least there'll be some outcome, some prognostic outcome. And more importantly, we don't have any answers, but we actually can be a hopeful story for someone else in that same position. And I think that's how we've embarked on it. So that's kind of my personal experience. But in just harking back to some of the ethical issues, is again very, very clear, educating the clinicians. As you said, it's that relationship. It's not just a piece of paper. It's that development of relationship with your families, some of whom have got very complex issues going on in their lives themselves. I work in a very, very deprived part of Bristol, which is the highest deprivation index. So they have got lots of intergenerational things going on. There is poverty, there is learning issues and crime, lots of things going on. At which point you've got to understand when they don't. So you've got to time it right. What is important for this family here and now, and then work on it. There's also the other issue that we may not continue to remain their clinicians after recruiting. And I think that's so important to recognize, because the results might come back, but you kind of discharge them and it may take a few years by the time the results come. How do you then cross that bridge if some unexpected results come, which then means contacting various other extended family members? And I think that's the bit we all do, because that's part of the journey we've embarked on. But it's also thinking, is there someone else who's probably better placed, like a GP or a primary care person who's actually holding the entire family, not just one person, not just the adult who has been the index patient. So it's just trying to think the ethics of it, because it's all about engagement and again being transparent with families.
I think you've put your finger on another element that's really important about the ethics. So in the same way as in relation to the sort of position of the individual patient, and we need to see them in families, which doesn't fit very easily with lots of the clinical ethics that we've been used to. It's also the case that a lot of the traditional clinical ethics has focused on the individual responsibilities of clinicians, whereas what you've just described is that we have to work out what the system's responsibilities are, because it may not be the same clinician who is enabling good ethical practice to be pursued. So these are both ways in which our paradigm of ethics has to be expanded from other areas of medicine.
Yes, I agree. And the other bit would be, again, which I think we can probably reassure quite nicely, is about the ethics about information governance, and how are we as data custodians storing information? How do we give with great ethics and discussion the access to research, and being mindful that it is, again, thinking along the same principles with my GMC kind of hat about the good for the common good and using resources equitably. But again, being sensible with equality issues, that a single condition doesn't get forgotten. So it's that right balance, that whilst we're doing common good, we might have a condition which might have a treatable medication, but we have to focus on that as well as research. So I think it's interwoven, all these ethical questions.
I completely agree, Latha. And that interwoven bit is something where we need to be able to think through what is the role of Genomics England enabled to improving that. And I think we've got issues around the good stewardship of information, which can't be left with an individual clinician. They can only do that effectively if the system supports them and their colleagues in doing that. But we've also got to be proactive. We've got to recognize the limitations of the current system. So one of the really important initiatives from Genomics England is the Diverse Data Initiative, because we know that without aiming to solve the problem, we will get a skewed data set and clinicians can't properly look after people. And that tells us that the ethics in this area has to do more than avoid things going wrong. It also has to work out what it means to do things right and what systems we have to put in place to do that. And I think that's a particular example of a shift we need to do across our ethics around healthcare. And if I speak to the sort of things that lawyers have got wrong around this in the past and some of our history, we've focused a lot of our effort on stopping things going wrong. And that has meant that we haven't spent as much time as we need to on thinking about how to make things go right. Because stopping things going wrong is almost always too late. And what we have to do if we're being proactive is work out how to set things up in a way that will make sure that the chances of it going wrong are quite small and the chances of doing good are much increased. So I think that's one of the key challenges that we have in Genomics England and as an ethics advisory committee, that the things we've inherited tell us quite a lot about things that have gone wrong. But actually what we're trying to do is to get our heads around what could go right and how to make sure it does.
No, and I also, you mentioned about diverse data. I think that's another important thing as we noticed in the COVID as well. There were lots of disparities in the social model and the inequalities that resulted in death, but also potentially HLA or epigenetic issues, which could have contributed. So we do have the COVID-19 genomic data sets. But it's again important to make sure that we don't perceive certain ethnic minority populations just not accessing or considering them to be hard to reach. I would say for them, Genomics England is hard to reach. So it's looking at it slightly differently and thinking, how can we reach them? How do we maybe use community workers or different, and maybe even clinicians? I think that they've got the best trusting relationships with their clinicians, and using them to recruit. As you say, even before things get more complicated, you recruit them earlier so that you go down the prevention route rather than the gone wrong route and then look for answers later.
So, Latha, I think you put your finger on something really challenging for a group like the Ethics Advisory Committee at Genomics England, which is that however hard we try to get a range of experiences and voices, that's not a substitute for getting out and hearing from people in real world situations. And I think one of the things I've learned over the years from my National Health Service work is that you cannot expect people to come to you. You need to go to them. So in COVID, when we were trying to understand why some groups were more reluctant to take up vaccines than others, there was no point in doing that sitting in your own places. You had to listen to people's concerns and understand why they were there. So one of the things we're going to have to be able to do as the Ethics Advisory Committee is work out when we need to hear more from people outside of the Genomics England system. And I'm a great believer that if it's right that we need to go where people are, you have to try not to reinvent mechanisms to do that. You have to try and learn where are people already talking about it and go and listen to them there.
Absolutely. Yeah, I think they listen because I do work as a pediatrician with a safeguarding hat. And I think, again, the same principles resonate. In child death work, for example, simple messages about cot deaths. You would think that if a professional tells the same message to a parent or a carer, it's better received if it's another family, a younger person, another lay person giving the same message. So it comes back to that, who is more receptive. So it could be a community worker. It could be, as you mentioned about vaccination, during the vaccination initiative, I decided early on that I'm probably not going to do a lot because I'm not an intensivist. How do I do my bit in the pandemic? I decided to become a vaccinator. And I thought, well, with my ethnic minority hat on, if I went out there to the mass centers and actually vaccinated there or in mosques or wherever else, I'm without even saying a word, I'm giving the message, aren't I? That, look, I'm fearlessly coming and getting vaccinated and vaccinating others. So please come. And I think that has helped to some extent, just trying to reach out rather than saying, oh, these people are not reaching us. It's got to be the other way around.
Have you registered for the Genomics England Research Summit? This one-day, in-person event will be covering the latest research and technology from the Genomics England research community. On the 9th of July, at London Business Design Centre, come and hear about advances in diagnostics, pharmacogenomics, therapies, and trials for rare conditions and cancer. We'll be joined by leading experts and inspirational speakers who will be exploring the present and future of genomics. You can register for free at genomicsresearchsummit.co.uk. We'll see you there.
I'm really enjoying this conversation, in part because I think it highlights just how valuable it is to sort of think about ethics a little bit differently. Historically, and certainly I think within the research community, ethics can be just associated with consent. Consent is the ethics issue, and if you solve for consent, then you don't have any other ethical issues to think through. And I think what this conversation is really highlighting is just how much broader the ethical considerations are. beyond that, it's still very important, and that consent can be that sort of anchor point for communication and engagement, but it's not simply a one-off. And to be able to think through ethics, not just in terms of risk or moving forward when things have gone wrong in the past, that there is actually a really positive aspect to it, which I think is critically important. So it's great to hear your thoughts about that different approach to ethics that I think does embed it much more in community thinking, in questions of equity. It's not just the individual. I suppose I want to follow up by just asking, where do you think the future lies in thinking about ethics, both for Genomics England and the Ethics Advisory Committee, but in the space of genomic research and medicine more broadly, given that it sits in this kind of very interesting and quite complex space between research and care in the clinic?
I've mentioned earlier in the conversation, I think about this as a common enterprise that we have shared stakes in. So academic researchers have a stake in trying to build a better, more robust evidence base. Clinicians have a stake in being able to offer something to the people that they're looking after. Families have stakes not just in their own immediate care, but they worry about their siblings, they worry about their children, their grandchildren. There are also, of course, industrial players. So people trying to build a business out of making better medicines in the future. There are government players trying to use public resources more effectively. So I think what we have to try and create is a mutual process where we recognize that everybody has overlapping but slightly different values that they're pursuing and trying to get out of it. And how can we make sure that we govern our work in a way that reflects all of those stakeholders and recognizes the respect that's due to them? So I think this is more like a sort of membership of a common project. And the problem with consent is it risks us saying you can be a member of this club, but only if you accept the terms and conditions that the committee has decided that's there. And that's not going to be adequate going forward. So I think we need to make sure everybody feels that they are respected, that they feel they can place their trust in the system that we're designing. As an ethics advisory committee, we have to ask ourselves, what justifies us suggesting to people that this is trustworthy? So we need to make sure we have good information governance, that people are not going to expose themselves to breaches of privacy if they take part in this. But we also need to make sure that we don't waste people's efforts. So if people are prepared to be part of the research project, we shouldn't have rules coming down on the data usage that say that we're going to reduce the value of that contribution by saying it can only be used for one project and can't be used for others, because actually that would not respect properly people's contribution to the process. So we need to ask ourselves not just about the protective element of trustworthiness, but that element that says we will make sure that you get as much as we can design of the things that you think are important from this project. Now, and they won't be identical for each group, and they won't be identical within each group. Different family members and participants will have different balances, but they all have to believe that this is a good club to be part of, and that they have been part of agreeing ways of working that they think will produce a better future that they want to be part of, and that they want to be proud of saying, we have helped create this future.
I kind of agree with all what you've said. I think it's most important not to forget, because I'm also a participant, like my trio sample is there in the pipeline, and I know my data is sitting there. I also have trust that there is good information governance, the data is secure, so it's reinforcing that. But it's also being very honest that it's obviously the data is there, but we can't forget the person or the persons in the center of it. So it's just not alphabets or sequences of alphabets, but it is that whole person, and that person represents a group of individuals, family members, different generations, and they have embarked on it. Even if they know they may not get hope, they might provide hope for others. So it's being therefore respectful. I think that is the first thing, I think, is the principle of it. And if you respect, and if you think it could be the same principle that we use in clinical practice, the friends and family test, because I've been on both sides of the consultation table. I think I've become a better doctor because I've been an anxious mom, and my anxieties were dismissed as being an anxious mom, and I don't care. As far as my child is concerned, my anxiety was valid. And so I would do everything to reach an outcome as to what's best for that person. And so it's made me a better doctor because I can see it from both the perspectives. And most of us are human beings, apart from AI technology looking at the data set. So we all have conditions ourselves. We've got doctors with health conditions, we've got clinicians, we've got academics, technicians, nurses, everybody who's got a friend or a family member or themselves having a health condition. So I think it's a fundamental principle is that friends and family test. How would I like my data stored? How would I like my data analyzed? Could it do this? Could it give me some information on how I would get cured or treated or being managed? And how would it affect my insurance? Or will it find out data about who is the father of this child, for example? So it's being honest and being honest about the uncertainties as well. So when I'm recruiting, I'm very clear that these are what I know, that I can tell you about the risks, but there may be other risks that I do not know about. And if you're honest about it and acknowledge what is the limit of the knowledge of science at this point in time, because you said there are so many stakeholders. There are researchers and academics who've got interest in some areas. It could have developed because of a family member having that problem. But whatever it is, that is a great interest because that intelligent mind is thinking ahead and we need to encourage that. It could be for writing up papers, doesn't matter. Whatever be the reason, if it's for the common good, that's fine. And is also thinking, how are we keeping our families in the loop? So you have newborns, you've got young people, sometimes with significant disability, so they are relying on a parent or a carer to consent for them. But some are not so disabled, but they have got needs, they've got rare conditions, but they can make their consenting issues known when they turn 16, for example. So it's the changing policies, and they can withdraw at some point in life or there may be a member in the family who doesn't want to be part of that journey anymore. It's allowing that to happen.
So I think that's a really interesting example you just touched on, Latha, where I may diverge a bit in terms of what I think is the key issue. So the right to withdraw, I think, is a really interesting challenge for us going forward, because we developed the right to withdraw in the ethics of research studies that had physical interventions. And it's really clear that someone who is being put to discomfort and is having things done to her body, if she wants to stop that, we can't justify continuing on the basis of it being a research project. But I'm less clear whether that applies to withdrawing data from data pools. And I think there's a few dimensions to that, which I hope as an ethics advisory committee we'll have a chance to think through a bit more. So one is the mutual obligations that we owe to each other. I'm not in these particular studies, but I do try and take part in research studies when I'm eligible and invited to, because I think research is important. When I take part in things, and when our participants have taken part, they're doing something in which they rely on other people participating, because the aggregation of the data is what makes it powerful. And I think we need to work out, one of the things we have to be honest about is, what are our mutual expectations of each other? So I think we absolutely have to hold on to the fact that people should be able to withdraw from further interventions. But I'm not convinced that you should have the right to say the data I've previously contributed that other people have relied on can suddenly be sucked out and taken out of it, because I think it's reasonable for us to say, if this is a sort of part of an enterprise, while you're part of it, you've made some commitments as well as having some entire, and that's part of the mutuality of the respect. So I think I personally would want to argue you can withdraw from new things, but provided that your privacy is not intruded on. So we're talking about data held anonymously. You shouldn't be able to say, don't process it anymore.
No. But what I meant was, from my perspective, I would like to be constantly involved and get, information through trickling. But I wonder, and I don't know what my daughter feels years down the line. She might say, well, I'm happy for my data to be used for research, but I don't want to know anymore. There are two aspects of that. And I think that's, if we are clear with that and say, continue with my data being used for research, but I don't want to get any more letters. And I think those are the kind of questions I face when I tell my families that these are the uncertainties. You have your blood stored. You may not be approached again for a resampling unless you have some other issues. But are we happy with this? And I think that's what I understand, and I try and recruit with that intention.
And that makes lots of sense to me. And as you say, you probably can't speak for your daughters now, and you certainly can't speak for them when they become parents for themselves and those things. But we do need to create an ethical framework which recognizes that people will change their mind on things and people will vary about what they want to do. But because we have mutual obligations, what that means and the control we can give, we have to be open and honest about what choices we can give people without undermining the enterprise, and what choices actually, we say, you don't have to do this, but if you want to be part of it, there are some common mutual obligations that are intrinsic. And that's true of researchers, it's true of clinicians, it's true of anyone who works in Genomics England or the NHS. But I don't think we've been very good at explaining to people that there's an element of this which is a package, a bit like when I bank, I allow the bank to track my transactions and to call me if they see something that looks out of the ordinary. It's a part of the protections from me. I can't opt out of that bit. I can opt out of them sending me letters and just say, do it by email or whatever. And I have some choices, but there's an infrastructure of the system which is helping it to function well and do the things it's aimed to do. And I don't think we've been very good at explaining that to people, because we've tended to say, as long as you've signed the consent form at the beginning of the process, it doesn't really matter what happens after that, you've been told. And that's not enough, I think, for good ethics.
And I think that comes back to the other issue about training those who are consenting. And I speak from personal experience. Within my own teams, I can see somebody might say, oh, I don't do whole genomic sequencing consenting. I don't have the time for it. And I might even have my organizational lead saying, when we had a letter come through to say, right now, we're no longer doing this, we're going to be doing this test for everybody, there's a whole gasp, because it's at least 2 hours worth of time. And how are we going to generate that time with the best of intentions? And I think that's where I think the vision and the pragmatic, the grounding, those two should somehow link with each other. So the vision of the Genomics England, with working with NHS England and with the future, the Health Education England arm that is now amalgamated with NHS England, is trying to see how do we train our future clinicians who will hopefully consider it as part of their embedded working, thinking and analysis. But also, how do we change the here and the now? The more senior conservative thinking people who are worried about how do they have to generate time to manage, who are already probably a bit burnt out or burning out, how do they generate time? And if we then discover new conditions where there is already bottleneck in various pathways, how are we ethically managing the new diagnosis, and how will they fit in the waiting list criteria of those people on the journey who are symptomatic? And I find that bottleneck, and when I have conversations with colleagues, I think that is the anxiety. How is that going to be addressed?
That you've sort of taken us around in a circle, haven't we? We started off thinking what was special about genomics, and we've reflected on we have to solve the problems of the health service. And I think that there's some wisdom in that, because we are learning how to do things that are not unique to genomics, but there's an opportunity in genomics to do it better, and an opportunity for us to help other areas of the health service do better too. So I think we've come around in full circle in a sense.
Which feels like a lovely way to wrap up our conversation. I feel like we've gone into some of the sort of deep ethical principles, but also really shown how they can be brought into practice, into the clinic, and brought to bear the thinking and the feelings, the hopes, the anxieties of participants. There's a very, very important range of different voices. So a very rich discussion. I'd just like to thank you both very much for joining us on the podcast. Thank you to our guests, Professor Sir Jonathan Montgomery and Dr. Latha Chandramouli, for joining me today as we discussed ethics in genomics research and practice. If you'd like to hear more like this, please subscribe to Behind the Genes on your favourite podcast app. Thank you for listening. I've been your host, Natalie Banner. This podcast was edited by Bill Griffin at Ventu Digital and produced by Naima Kalachan.